first got the idea, I heard it from Haitians 30 years ago, and we were trying to set up a decent tuberculosis treatment program. And we knew tuberculosis is a chronic disease like diabetes. It has a cure, so it's not like diabetes, but it takes many months to do so. And we thought we had free care at the clinic that we'd built there, and yet we had poor outcomes. Why? Well, we found out the reason was, of course, we needed to move the treatment out to the patients and their families, and that there were many hidden barriers just to get to the clinic. So we started working with community health workers who were called accompagnateurs in the local parlance. And we thought, wow, this is a great idea for other problems that would go on beyond, a short amount of time in a hospital and a clinic, which is to say most of them, right? And so we started pushing for that model, brought it back to Boston, to say we need this in Boston too. We have great hospitals like the Brigham where I work, but in the shadow of the Brigham and the other Harvard teaching hospitals, people facing other problems, not the ones in Haiti, but housing instability, poverty, racism, the problems that have made it difficult for some people in our cities. They need this too. So that particular speech is to say, well, what about foreign aid? You think this ADD approach that we've seen after Haiti is a good way to approach foreign aid, where everything is so short-term, where there's so much conditionality? Or might a more solidarity-inspired endeavor, like actually walking with your partner, be more relevant to the world we live in, driven by inequalities, but by people who do want aid to work on both sides of that equation? That was a longer answer than you thought, but
no, I expected that we wouldn't get in another question. But that issue of accompaniment in a healthcare model, from Haiti to Rwanda to here in the United States, what is wrong with our system? How would we change it to be the model you're talking about?
Well, what's wrong with our American system is that we don't have, or there are maybe many problems. Some of them being addressed. We have so much money going into the system, so we ought to have a good system. But one of the problems, and one I'm obsessed with, is how do you reach from a hospital to a community-based health center and then on into people's homes? That's what we've had to learn in treating chronic disease. When people said you couldn't treat AIDS in Africa, we said, well, that's not true. I mean, here's a model that would give you better results than in a sprawling American city, and you could do it in a rural area. This is a model that could help you treat major mental illness, diabetes, etc. So I think we've made progress, and now what we need to do in the United States is find a way to train and license and reimburse lay people who are community health workers to work in the home and with patients wherever they live. Make it convenient for the patients. These treatments for one or two diseases at a time that people with chronic illness face, including elderly people, they're difficult and annoying, and you have to go back and forth. And you go to other countries like China, which I don't know very well, but when I was visiting hospitals in China, they were asking people with chronic disease to go get their prescriptions filled every 2 weeks. And they would come back and stand in long lines. And imagine if you're frail or sick, and you're asked every 14 days to go back to this overcrowded hospital to get your prescription filled. It makes no sense at all. And that's the basic pathology of the American healthcare system. It doesn't have a good community-based or home-based component. There are other pathologies too, and they're being addressed, I hope, increasingly.
Well, you've lived and worked in Rwanda for a long time. And I'm wondering if you could talk about your work there and what you think we can learn from how Rwanda has transformed their healthcare system.
Well, the work in Rwanda has been very uplifting for Partners in Health, for me, for our partners from Harvard, in part because we made a bet almost 10 years ago that if we could, as a collective, take this model, I'll call it accompaniment, but I'm not just talking about community-based care, I'm talking about rebuild a system that has hospitals, clinics, and community-based care. If we could go to a place with great need, especially maybe in terms of infectious pathologies like malaria, TB, HIV, which we know a lot about in our team, post-conflict setting, maybe one even written off as hopeless, but with a government committed to rolling out basic services in health and education to poor people in rural areas. If we could find all that, we would see something miraculous happen in the course of a decade. And we did. That's why we went to Rwanda. We went with the Clinton Foundation and other partners and worked with the Ministry of Health of Rwanda. And that, it's been the most rewarding decade in my life as a doctor, just to see how the reversal of fortune, how quickly it could happen. Just to give you some numbers, the life expectancy in Rwanda has probably doubled over the last 10 years, and the declines in mortality, especially among children, women in childbirth, declines in mortality among those who already have tuberculosis, malaria, and AIDS, these are the steepest declines ever recorded in human history.
So explain exactly what you did.
Well, we worked with the Rwandans, as did many other people, and I'm not suggesting that we were. There are many other groups, but the key is working with the public sector. After all, eventually, if people have a right to health care, it will be the public sector and not non-governmental organizations or universities from the United States that will confer those rights. So we worked to build a system, and the system stretched, as I said, from community health workers to clinics where the majority of care is given. Those are run by nurses, to having in every district a hospital. Partners in Health ended up building or rebuilding 3 of the 30 district hospitals, and including even starting a cancer center, probably the first cancer center in rural Africa anywhere. But it all fit into a system, and they're called vertical programs in public health. So an AIDS program or a family planning program, those are vertical programs. What the Rwandan government and authorities said is, we want those vertical programs to strengthen our health system, our Rwandan national health system. And we did do that, and we were pushed to do that. And the result is, I think that's why that decline is more steeper in Rwanda than in other places, and why it's the only country in sub-Saharan Africa on track to meet all of the health-related Millennium Development Goals.